Good morning, everyone. My name is Dr. Erik Mittra from Oregon Health and Science University in Portland, Oregon. I want to thank the organizers of this session for inviting me to give this talk. The subject is PRRT in G3 NENs. I don't have any relevant disclosures to this talk. Some general disclosures are listed below. The outline is as follows. What I'll be presenting is primarily the work of the North American Neuroendocrine Tumor Society, NANET's G3 working group. This group has been in existence for approximately 1 year now, and we're getting very close to finalizing our results. And so much of the content is coming from this working group. But specifically, I'll discuss some of the aspects related to histology, and then discuss imaging, and then finally focus on the main topic, which is PRRT. So a little bit more background on this working group from NANETS related to G3. It's led by Dr. Jennifer Eads, and there are a variety of other physicians that are involved, representing a variety of different specialties. You can see some of the names listed there. And as mentioned, we are very near completion, so this should be published in the very near future, and you can look forward to that. With regard to pathology, these are the classification from the World Health Organization in 2019 was the latest update. And you're probably relatively familiar with the fact that we grade these tumors based on the Ki67 value listed on the right or the mitotic rate. And for the purpose of this talk, when we're talking about high-grade malignancy, we are in this area here, which can be further differentiated based on histology between well-differentiated and poorly differentiated categories, all with the same Ki67 and mitotic rate. Some other numbers to keep in mind are listed below. So one is this differentiation between well-differentiated and poorly differentiated is primarily a histologic classification, but many people use a Ki67 value of 55%, and you'll see that throughout this talk, including in clinical trials. Also keep in mind that many patients do have a heterogeneous disease. So although one biopsy might show one specific grade, the patient may in fact have a variety of grades of tumor. And lastly is that patients can develop an initial type of grade, and then subsequently it progresses to a higher grade called grade progression. And that's also something to keep in mind if you're dealing with a biopsy specimen that may be older. With regard to conventional imaging, all the different modalities listed here certainly have a role. Ultrasound is, of course, limited by what can be accessed by the transducer, but it's particularly useful, for instance, for ultrasound-guided biopsies. CT definitely forms the cornerstone of imaging of neuroendocrine tumors, and it's important to keep in mind that you should always use multi-phase contrast-enhanced scans because some tumors are hypervascular, whereas others are not. And so looking at the arterial phase as well as the portal venous phase is important for identifying all of the tumors within the body. And MRI also has a very important role, but primarily for liver and pancreas. It doesn't do as well for the rest of the abdomen or the mesentery, and equally for the lungs. And even for the liver and pancreas, it's important to try and use multi-phase contrast-enhanced scans. Even better would be to use a hepatocyte-specific agent such as EOVIST, because that really helps identify the lesions with the greatest amount of accuracy, especially when looking at size differences between different MRI scans. Whichever modality is used, such as CT or MRI, it's important to try and continue that same modality for the future so that the scans are truly comparable. We often have patients coming from community hospitals where one modality is alternated between the other, and that's very difficult to evaluate progression in that scenario. For molecular imaging, there is, of course, a variety of different types of modalities that can be used, shown here. And this is, of course, US specific, so there might be some variances that are present throughout the world and in India. The first four that are listed there are, of course, examples of somatostatin receptor imaging, whereas the bottom four that are listed are examples of PET imaging. So if you use a combination of somatostatin receptor and PET imaging, I've highlighted the 3 radiopharmaceuticals that are most commonly used. Within the US, it's quite exchangeable between gallium-68 and copper-64 dotatate, I would say. And we don't really have a strong preference between one versus the other. They have individual pros and cons between them. And then FDG is primarily used for higher grade tumors. So let me show that more specifically here in this publication from Michael Hoffman in Australia, showing that the same patient, as mentioned before, can have heterogeneous disease. And so for patients with lower grade tumors, those that are below Ki67 almost always express somatostatin receptors and are therefore better evaluated with dotatate, whereas those that express higher grade tumors, typically over Ki67 of 20%, will lose somatostatin receptor expression but show glucose uptake with FDG. And so really in this range of mid-grade tumors, you might need to actually evaluate the patient both with a dotatate scan and FDG scan, and as the Ki67 gets higher, then you would switch mostly to FDG. So this can be depicted schematically as follows. Below Ki67 of 10%, primarily only a dotatate scan is needed, and above 55%, only an FDG scan is needed, but many people would advocate that within 10 to 55%, using both modalities for the complete evaluation of the heterogeneous tumors are what is most useful. This has been taken to the point of having a different grading scale based on both somatostatin receptor expression and FDG expression. And if you look at the categories of P1 through P4, in this area, there is variable expression of both of the radiopharmaceuticals. And further, what was shown in this particular article is that this relative expression between the two radiopharmaceuticals can actually be used to prognosticate the disease for the patient. So that can potentially be very useful, although this is something that still is being fully evaluated. Okay, so with that background in mind, then let's jump into the main topic, which is PRRT in this category of high-grade G3 neuroendocrine neoplasia. So the first thing is, as most people are likely familiar, lutetium dotatate was FDA approved in 2018, and it is only indicated for low-grade or intermediate-grade gastroenteropancreatic neuroendocrine tumors. So anything outside of that, such as a different subtype, would be considered off-label, and certainly G3 would fall within that area as well. However, having said that, there is some preliminary data that PRRT does appear to be promising for G3 NENs, and there are several ongoing, relatively large trials. The two largest ones that are currently ongoing are the NETTER-2 trial, sponsored by AAA Novartis, and then the COMPOSE trial, which is still in the early phases, which is sponsored by ITM. Both of those are looking at the group of well-differentiated G2 and G3 neuroendocrine tumors. And there's also a fair amount of work that's being done in terms of combination therapies, such as capecitabine or PARP inhibitors, because they could potentially accentuate the utility of the radiation from PRRT, or in the case of PARP inhibitors, work in the same way in terms of creating DNA damage that the radiation does. So there are several ongoing combination therapy trials as well. In either case, for this area of G3 NENs, again, somatostatin receptor imaging is critical for eligibility selection, because if there isn't sufficient somatostatin receptor expression, then it certainly wouldn't be a good candidate for that therapy. But it's also potentially useful, again, to evaluate with FDG as well for the prognosticability, and to ensure that truly all the tumors that are being seen by anatomic imaging and by FDG also show somatostatin receptor expression. You wouldn't know if there are other areas which don't show sufficient somatostatin receptor expression unless you do all of the other types of imaging. And what appears to be, based on this preliminary data, is that there is a limited role for poorly differentiated G3 or the neuroendocrine carcinomas. But again, we'll see some information here. So let's look at some of the retrospective data that's been published so far, because again, the prospective trials that I mentioned are currently ongoing and won't be published for a few years. So this is a relatively small study from the Australian group looking at 28 patients with a variety of different grades of tumor. You can see that they also had a variety of different subtypes of disease in terms of their primary, and many of these patients also did actually have FDG-avid disease as well. So they were treated with the lutetium-177, and the overall median progression-free survival was 9 months. However, there was a big difference between those patients who had a Ki67 of less than 55% versus those who had higher than 55%. So you can see that the group that had less than 55% had a median PFS of 12 months versus those that had a Ki67 of greater than 55%, which was only 4 months. So a big difference between those two groups. And it should also be pointed out that there was relatively limited toxicity across all these patients. Grade 3 or 4 lymphopenia or thrombocytopenia only occurred in a very small number of patients, and there was no renal or liver toxicity noted whatsoever. A slightly larger group of patients, 69, from Dr. Baum's research group in Germany. Here, again, a variety of different subtypes of tumors, and they did have both patients with well-differentiated and poorly differentiated histology, and actually the results were very similar to what we just saw from the Australian publication, which is that the median progression-free survival was 11 months for those patients with a Ki67 less than 55%, and only 4 months for those patients with a Ki67 of higher than 55%. This particular paper also looked at the role of imaging and whether or not you could prognosticate using both FDG scans and the somatostatin receptor PET scans, and they did find that the higher the uptake on somatostatin receptor, the better the outcome was. The higher the uptake on the FDG scan, the worse the outcome was, which is now something I feel that is relatively well known in our field, but the specific cutoffs and how we use that information to decide the therapy still is being evaluated, but at least we generally have that understanding. And this paper also showed the same thing in terms of toxicity. There was very limited significant toxicity in terms of hematologic function, and there was no decline in renal or hepatotoxicity seen. This was an interesting patient within that group from Dr. Baum, which this particular patient was treated with up to 10 cycles of lutetium dotatate over many, many years. And you can see that they initially had a very good response and had a stable period without evidence of disease for many years. And then when the patient recovered, they were treated again with multiple cycles of lutetium dotatate and again had a good response, and there was no toxicity over this long period. This is an unusual example, but showing in a patient with well-differentiated high-grade neuroendocrine tumor that they can truly have a very good benefit for a very long period of time with this sort of approach. And then this is the largest retrospective publication that I was able to find of approximately 150 patients, again, a variety of different tumor types, and the median progression-free survival in this case was about 14 months with, again, very limited toxicity. So all this data, although retrospective in nature, as I mentioned, is definitely supportive of the fact that PRRT does appear to have a good role in the treatment of patients with well-differentiated G3 tumors, less of a role for those patients with poorly differentiated G3 neuroendocrine carcinomas. So, in summary, very important to keep that differentiation in mind in terms of well-differentiated versus poorly differentiated histology, and also highlighted the importance of these different Ki67 values, 3% to differentiate between well-differentiated intermediate grade, low grade versus intermediate grade, 10% for when you would consider starting to get an FDG PET scan in addition to somatostatin receptor PET, 20% the difference between intermediate grade and high grade, and then 55% for the differentiation between well-differentiated and poorly differentiated high-grade tumors. So I discussed the universal role of conventional imaging for all of these patients, and of course the critical role of somatostatin receptor PET for selection of patients for PRRT, and the role of FDG for higher grade tumors and for possible prognostication in this group. And I would say that the preliminary data seems to support that the role of PRRT is primarily limited but convincing for patients with well-differentiated G3 neuroendocrine tumors. But this definitely needs to be evaluated in the larger ongoing prospective clinical trials that are happening right now. So we'll be excited to see those results when they come out. So with that, I will stop, and thank you very much for your attention.
Thank you, Dr. Mittra. I'm sure you are live now for a couple of questions. It was a wonderful talk. Though the data is limited, you try to cover most of the aspects of G3 neuroendocrine neoplasms. I have a couple of questions for you, especially with regards to G3 NENs. There have been a couple of studies where capecitabine temozolomide has been used for redifferentiation. In order to redifferentiation, in order to get the G3 tumors back to having gallium dotatate expression, that is somatostatin receptor expression, so that these tumors can be treated with PRRT. Do you have any experience or clinical data to support this, or any kind of trials which are ongoing for this?
Yes, thank you for that question. And once again, thank you for inviting me to give this presentation and be a part of this symposium. To answer your question, here in the United States, again, we're quite limited, I would say, with the capacity that we have to do some of these combination studies. I completely agree with you, as was mentioned, that this type of combination approach is one of the ones that are being looked at in some prospective trials that are ongoing. But yeah, we don't have any specific data on that as yet. I am hopeful, though, that we will have some good data from that soon.
And in particular scenarios where you have DOTA scan positive but FDG scan negative in G3 NENs, do you still add chemotherapy purely based on the histopathology of high grade neoplasm, or you just stick to PRRT?
Can you repeat that question again in
So
terms
when
of?
you have a high G3 NEN which is dotatate positive but it is negative on FDG PET, there are scenarios where you get FDG negative but a high grade neuroendocrine neoplasm. Purely based on the histopathology of a high grade neuroendocrine tumor, do you still add chemotherapy, or you just stick to PRRT just because the tumor is only expressing somatostatin receptors?
Yeah, again, a very good question, and one that's a little bit difficult to answer in terms of a uniform response. I think in terms of clinical applicability within the United States, especially, we would have to stick to only one type of modality versus the other. As Dr. Das also mentioned, combination therapies are very difficult to do for us clinically, although it can be done as part of research trials. So for the most part, we would just stick to PRRT in that indication. But I think those combination approaches are very important to look at in the future.
We have one question from the audience from a medical oncologist.
Somatostatic analog and wait for the progression to use PRRT.
In case of low volume G3 NENs, do we need to give PRRT just because it is expressing somatostatin receptors, or we can use somatostatin analogs for that? And then
I think that's
use PRRT as an option when there is disease progression.
correct. Yeah, I would wait to make sure that there's disease progression, even with patients with well-differentiated G3 tumors. Sometimes, surprisingly, the disease can be relatively stable for quite some time, and I think using somatostatin analogs, if they are still available and working for the patient, are a good first choice, and then saving PRRT for when progression happens.
Thank you, Dr. Mittra. Thanks for the wonderful talk, and you have answered all the queries and clarified doubts regarding the grade 3 neuroendocrine neoplasms. Thank you for taking out time at such odd hours, and pleasure to have you. I think there's one more question from the audience there. Uh, how would you
Yeah, I think I see the question from in the tab. Yeah, how would you go further if you find equal uptake on FDG scan and dotatate scan in G3-NEN? In that case, as Dr. Das mentioned, there's prognostic value in the information from the FDG scan, but in terms of choice of therapy, we primarily base it on the dotatate scan. So if there's sufficient uptake on dotatate across all the lesions, even if there's uptake on FDG, we would probably first go with PRRT. But again, I think this is a perfect example where combination therapies in the future are probably going to be the right way to go. Yes, that's Dr. Das just mentioned exactly what I said.
Great. So that pretty much sums up our discussion on the therapeutic aspects of neuroendocrine tumors.
If there's a high volume disease in G3, would you prefer to use PRRT plus somatostatin analog, or you would prefer a K10 plus PRRT kind of approach?
Okay, so in case of again high volume disease in neuroendocrine setting, do you add somatostatin analogs to PRRT, or you just leave it at PRRT and or add any other chemotherapy? So basically, is there a role of somatostatin analogs in case of grade 3 neuroendocrine neoplasms in addition to PRRT?
Yeah, all of these are wonderful questions. There is again data from the NETTER-1 study in terms of how it was developed, as well as some retrospective data on lanreotide that using the combination of somatostatin analogs plus PRRT appears to have some benefit over PRRT alone, but there hasn't been very good separate randomized information on that, so it's a little bit hard to say. I do think that if the volume of disease is high, it's probably not a bad idea to use that approach, knowing, however, that the data isn't entirely there.
Thank you, Dr. Mittra. Thanks for having participated in this session, and your experience has helped us in learning new things. Thanks for joining once again.
Yeah, thank you so much for having me. Really appreciate it.